because I gave that talk yesterday. I have a different talk for you, I thought. And it's about training laparoscopic surgery in the UK. Is that okay? Or I'm happy to give the other talk again. Okay. So first of all, thank you again for having me. We had a fantastic time yesterday operating here in Pančevo and today. And as you heard, my Serbian is still improving. It's still not enough to give this talk in Serbian. It is better since last night, but still working on it. So I was asked to come here and to talk a little bit about training and setting up training programs in laparoscopic surgery and other techniques. And I have to say what I have seen so far, what you have achieved in this very short time with limited resources, I'm not sure if I can tell you much, because you have already established such a fantastic structure here that seems to work, and I'm sure we'll hear more about it from Miljan later. But what I'm trying to do is I will talk to you about a few things. First of all, I will try to tell you why this headline that was last year in the British news should not happen anymore. I will explain to you what that curve means. I will explain to you why we should not try to be propagandistic about certain techniques, and that we shouldn't behave like tribes fighting against each other based on techniques. I will explain to you why some surgeons are treated like rock stars and why that is also problematic. And I will finally try to explain to you why education is really the key to most of these problems. I will also show you that Europe is actually one of the leading regions in the world, or if not the leading regions in the world, with established training programs. So it's far ahead from America and from other parts of the world, and I will explain that map to you with more details. And finally, I will also mention why setting up training programs and doing education in a structured way can really save money to the healthcare system. So I'll try to go through all these things, and I will do this a bit slower than I just did. And I will try to explain these things also underlying it with evidence, because I think we have more and more proper evidence that we can prove these things. But I start here again with this headline. So this was last year, 2018. Patient died after robot surgery error with Da Vinci device. Now, what really happened, I'll show you here, this is a bit more from this article. It says, a patient died after heart operation in which the surgeon was using the robot for the first time, even though he had not been trained and did not have any support. So what really happened is, this was in Newcastle, in a city in the north of England. This particular cardiac surgeon took the machine, put it in his operating theatre and did a mitral valve replacement robotically. He never used it before, he did not have any training. He had a representative of a company that was dealing with the valve in theatre, but no one from the robot company, and he had no proctor, and the patient died on table. And the headline that came out was basically, the robot killed the patient, but the robot didn't kill anybody. The surgeon killed the patient, and the surgeon killed the patient because of his inappropriate behavior and his lack of insight of how to do these things properly. So this should never have happened, and particularly not last year or in our times now. When I go back a little bit, this is what it looked like more than 10 years ago in England. Laparoscopic surgery, the rate of laparoscopic surgery for colorectal was below 5%. Those who were doing it, they were looked at a little bit of kind of strange magicians and witches doing that type of surgery. They were not really recognized, and people were doubting that this is the right thing to do. So that was the kind of environment. But then there was more and more evidence coming out, and I have to explain to you a little bit how healthcare works in the UK. I still struggle to understand it really, but just I'll give you a few basics. So there is an institute called the National Institute of Clinical Excellence, which is, the abbreviation for it is NICE, which is a nice abbreviation. And what they do is basically they review evidence on a regular basis in all fields of medicine, and then they come out with a guideline. They say, has good evidence, we need to offer this. So they reviewed laparoscopic surgery for colorectal cancer, and they said, well, there is now enough evidence, we should be able to offer this to patients. And when they put out a guideline like this, it has to be implemented within 3 months in the whole country, everywhere. So they don't want that a patient in London gets better treatment than a patient in Edinburgh or somewhere else. That was not possible because there were no surgeons offering this surgery. There were only very few who could do that. And that's why what they had to do, they waived it immediately. So they said, we put the guideline out, but you don't have to follow it for now. And that forced them to do something. And it basically forced the health minister or the health ministry to fund a project which will help to train up surgeons to a standard that is sufficient to deliver that. And that's how LAPCO was born, or the laparoscopic colorectal, or the national training program in laparoscopic colorectal surgery. And this was in a time, it's very different than now because we had no idea how to do that really, because it was never been done. And basically a lot of mistakes have been done, as you would imagine, at the beginning of such a project and throughout the whole project. If we were to do it now, we would start completely different. So for LabSerb, you are in a more comfortable position because we know now kind of what is the right thing to do and what is the wrong thing to do. But back then we had no idea. So basically what happened was a bunch of people who were doing laparoscopic surgery self-declared them as experts, and they came together and had a chat. How should we do this? And they came up with some ideas, but eventually what happened, they formed a core group, a steering group, and they appointed two different leads. One was the educational lead, which was mainly for the educational bit, and the other one was the clinical lead. He was kind of overseeing the whole program. They identified centers of excellence, again, self-declared more or less. These were just people who said, we do it and we can do it. And they said, these are our training centers. And there were about 10 or 11 in the end. And then each training center got allocated surgeons who were to become their trainees. And they were all senior surgeons, so they were not like surgical trainees. They were not like young surgeons. The aim was to train up the senior surgeons first. And then the whole thing was given a name. And then we started to kind of build up a structure to it, because again, we didn't really know how to do it. You know, do you just need to go on a course, or how do you do it? We all felt that it's probably not good enough if you just go on a course, because disasters will happen. So this is how this structure came up, and maybe this is something that looks familiar to you as well there with LabSerb. But the idea is that we select the surgeon through an application process. There will be a course that they go to, a workshop where they did mostly cadaveric, sometimes also work on pigs. And then there will be a period of supervised training where we have proctors going to them, or they coming to the hospital of the proctor to work with them. And then finally they get signed off and they continue their training on their own. And the idea was that that would reflect that kind of system of how you develop through education, being beginner and advanced beginner, becoming competent, and then finally proficient. So we thought this is all educationally very well funded. The problem was it was not, because again, we were quite ignorant about this. We didn't know that much about educational theories. But looking back, maybe this is also good, because if you think too much in theory, you will never set it in practice. So having had that kind of certain naive approach was not bad. What we did know at the time, because we analyzed the data from around the world, was that if an expert is present in theatre, even if the expert is not performing the operation, but is just assisting or just talking someone through the operation, the outcomes are comparable to when the expert is doing the operation, him or herself. Whereas if that person is not in theatre, the outcomes will be worse. Again, maybe this sounds very kind of simple, but this was the first time we could actually show that and demonstrate that with proper evidence. What we could also show is when we analyzed data of surgeons who started laparoscopic surgery without any help, and a lot of the people who were doing laparoscopic surgery at the time, they did exactly that because they had no one to teach them. It took them about 150 procedures to reach a level where they had stable results. So their learning curve was 150 procedures. That's a lot of cases, that's a lot of patients. And it also, when you think about it from an ethical point of view, it's very problematic because you're basically counting the numbers of problems that you caused because you were not properly trained. So these are people, these are individuals. So it's a bit like walking through the battlefield at the end of the battle and counting the dead bodies. That's basically what we were doing for a long time. And then we defined, it took me this many deaths to get to the level where I'm now good. Or it took me this many complications, or whatever you want to choose. So it is a wrong concept, and we can't do this anymore. We also started to see that individual surgeons, although they're all senior, they don't develop in a similar way. Some surgeons are learning quicker than others. And you could argue some surgeons never learn. But that's usually not because they are not able to do it, but it's usually a lack of insight. But just acknowledging that people are developing at different speed was again an important insight that we had. And basically what we started doing, because we didn't know what we were doing, we started measuring everything, and we were trying to measure all these different things that we implemented and then look at the data and see what we can come up with. One of the first things that we did, and again for LabSerb, I think you have a similar concept, is to use this so-called gas form. This was just like a report on a proctoring session. So when someone went to train someone, they filled in this form afterwards, and it's basically just broken down the procedures into generic steps. And for each step they were scoring it was not a judgmental score, it was just look at how much input did the trainee need for that. And very quickly we could then develop these curves. Again, at the bottom you see different trainees were developing at different speeds. And at the top you can see that different tasks of the procedures were also learned at different speeds. So there were certain things that were learned very quickly and more complex things took more time. Again, it sounds very obvious now, but back then it wasn't. And then the idea was that they have a signing off procedure at the end, where they are assessed whether they are now competent or not. And the way it worked was basically that if there was a trainee in a small place called Burton next to Nottingham was a training centre, they had a training interaction, then the trainer and the trainee agreed, I think now you're good. Then the trainee had to record 2 cases and record them on some sort of memory storage device and send that to us. We were at the time at Imperial College in London, and we were de-identifying all the data and sent then the videos to 2 independent assessors, and they were assessing it using this tool here, which was a video assessment tool. So they went through the video, it was a full-length video, they had to score every bit of the video, and that was much more scientific the way we developed that tool, so that had much more foundation. And with that we could then start identifying those who were competent based on this score alone. So without knowing the surgeons, without knowing anything, just looking at the video and assessing it in a structured way allowed us to identify those who we think should be competent versus those who need more training. And more importantly, we could then also later demonstrate that there was a direct correlation between the score from the video and the clinical outcome. So it had a direct impact on how the patients did. So if a video scored low because it was of low quality, the patients had more complications. The patients had a lesser quality of specimen, etc. And again, this was something that was shown for the first time, that with education alone or with the educational methods alone, you can actually have a direct impact on the clinical outcomes. when we released them from the program, we could see that they could retain their skills. So you see, the only thing that changed when we left them alone was conversion went up. Quite a bit, you know, doubled almost. But we didn't think that that was a bad thing, because these people were still learning, and they had enough insight, obviously, to convert if they felt that they had to. But all the other clinical outcomes, the more relevant ones, like complication, leaks, reoperation, and mortality, remained the same during the training when they had an expert present, and then in the immediate cases afterwards when they continued on their own. More recently, and I ask you not to take any pictures because it is still in submission, and that's the final paper that will come out. LAPCO has actually finished in 2014, so the program is not active anymore, but we have now the long-term data. And what we were doing is to analyze the outcomes of the surgeons who came to the program before they started the program, so a 3-year period before the program, and then a 3-year period after the program, so once they were signed off. And we're comparing those with people who did not come or who did not attend the program. And that was national, so that was not like some selected group, this was like everybody. And we case matched them individually with the control group. So there were a total of 72,000 cases that were analyzed. And when you look at that, so you see, on the left side, you see how much uptake of laparoscopic surgery happened for these individual surgeons. And you can see that the LAPCO surgeons increased much higher than the non-LAPCO surgeons. So these are the ones on the left side, on the right side of the screen are the ones that did not attend the program. But more importantly, when you look at 90-day mortality, you see what happened with the LAPCO trainees. It dropped significantly from around 3% to 1%, and it remained the same for those who did not attend the program. So whether this was just laparoscopic surgery, I don't know, but you can see the difference mostly in laparoscopic cases. So the ones that were not trained had more mortality in their laparoscopic cases than the ones that were trained. So here we're not talking about, you know, maybe there's a bit of a leak or something. Here we're talking about people dying. And people died because the surgeons were not trained. So that is, I think, the deepest impact of the program and of what we can see now. And I think that's something that will make, or has us make us think how we are going to take this in the future. And you know, the approach that you have taken in this country is extremely commendable, because you have taken this on board and you're just doing it. And I think you're doing a very great thing right now. The potential savings, I'll just show you this. I don't want to go through all these numbers, but we had someone who was crunching all these numbers. And I just want to say that much. In the UK, the government spent around £10 million, so that's about 11, 12 million euros, or maybe not anymore now, it's probably 9 million euros now, on this program. That's a lot of money. And here I think you have spent a fraction of that, but you have achieved the same thing, or not even a better thing. And yes, at the time, obviously, we had to make this all up. We didn't know what to do, so it required probably more investment. But whatever you do, and this is for the UK, what we can say is for every pound, for every euro, for every dollar that was invested into the program, they saved 3, because of shorter length of stay, because of saving for complications, etc. So whatever investment you make, it will come back. It will come back 3 times. So it's not a loss. So this is something you should show your Ministry of Health to convince them to invest further into the program. Now at the end I will just mention just a few things about the new kids on the block, because you know, like you did here in Serbia, the program had an impact also in other areas and still has. So I just mentioned 3 things very quickly, because these are all techniques that are evolving and where LabCo-like programs have been started. But what is interesting is with every technique that is introduced into surgery, you will see different things happening. It usually starts with this. Someone comes up with something and does it, and then tells everybody how great it is, and everybody believes it, and people's expectations are starting to rise. They think, you know, TATME or robotic surgery or whatever you take, this is the new thing. And then more people are kind of advertising it, and they think, oh, this is really great, this is the next best thing. And it reaches that peak of inflated expectations that are unrealistic. And then more people start doing it, and they start having problems, and they start seeing maybe it's not that easy, and it starts dropping down. And this is what happened to transanal TME very much so. I think that's where we are with transanal TME right now, because suddenly people saw there are problems. And it takes some time to kind of come up to a realistic level of where you can actually use a technology or a technique and it makes sense. You know, like Alexei, he talked to us about ICG lymph nodes, sentinel lymph nodes. Everybody thinks probably when you see that, this is fantastic, we have to do this, we have to all do this. And it will go through the same thing. In the end, you will find the right application for this technique, which I'm sure is great. With TATME specifically, transanal TME, there's also the problem that certain surgeons have been kind of using it as a vessel to promote themselves, and they were treated like rock stars. And it was not helpful for that technique, because again, what happened with that was that the expectations were just going up and up and up, and were never realistic. And it's only now that you can see that this kind of storm is coming, where we have reports from Norway, where they have these multifocal recurrences in the pelvis that they never seen before, 10% or more. And you see the same thing is happening as well in the Netherlands now, in long-term follow-ups. So there are problems with the technique, and we need to address them. We try to address them through kind of a collaborative group in the ESCP, the European Society, and come up with some guidelines. And I don't want to bore you with these guidelines, but I just want to highlight one specific item, and that was part of the guidelines were on training and implementation. And we said, you know, a formal structured training pathway should be implemented or should be completed to safely implement TATME. A lot of people agree with that. And they said it needs a course, it needs a training curriculum that includes proctoring and the workshop and all these kind of things. So the same structure like LabCo. So you can see here how things were repeated. So the problem was that there was no training program around really for TATME. There were lots of courses, and exactly the same mistake was done again. People went on a course, then they went back, they did a case, they failed. So that's not how it works. But there are two training programs for TATME now. One is in the Netherlands and one is in England. And they're very similar, and I don't want to go through them in detail. They have similar conditions, how to enter them, and you go through them. Again, you see the structure, it looks very similar to LabCo. So this is all kind of coming out of that. And when we look again at the clinical results, the ones that are done within the program have actually quite reasonable short-term outcomes when compared to cases performed by experts. It's the same story. It repeats itself, and it just shows again, it works, but it has to be done at the beginning and not when it's too late, when the problem's already started. This is the assessment program of the or how we assess competency in TATME. Is now online, but you see it's the same structure, it's the same thing again. I've spoken yesterday about LabCME, and I just want to mention a couple of things, so I'm not going to repeat this for the people who've already seen it. But again, I just want to mention again this is the training program for LabCME that has been offered through the European Society again. And look, when you go to their website, what do you find? The same thing again. It's always the same structure. We are now much more refined with how we deliver it, so we pay much more attention on how to standardize procedures, to teach the same thing, not that everybody is kind of learning something different. And these are, this is actually from earlier this year, some of the centers and delegates that have been participating, and you can see there's also a green dot in Belgrade, and that's Miljan, who came to our workshop and finished the training. And that, again, is something, so what we have tried to do in the UK, or what you're trying to do now in Serbia, I think can also be done internationally, it can also be done on a wider level. The structure is always the same, it's quite simple and straightforward. I'm not going to talk about robotic surgery again, but you can see, I just want to show you this because of my final slides, what I actually wanted to tell you, or the message I wanted to give you, because you already heard from Amjad about it. So this, what you can see here, is obviously a simulator, it's not a real patient. And you can see the surgeon who is doing this, that's the first time he's sitting at this machine. And, you know, it's not, it doesn't work that well yet, but it's actually not that bad. So the machine allows to someone who has never been doing this to be quite good already at the beginning. And it's more impressive when I show you who the surgeon was. And that's him here, that's my son, Nikolai. He's 6 years old, and that was him operating. So, you know, even a small child can just sit there and start doing something. And again, you have to be aware that, or you shouldn't be fooled by that it looks easy and you can just do it. It is still difficult, it is still requires a lot of training. And I think the robotic training in Europe at the moment is on the right way. And guess what? They're using the same structure again like Labco. So this is how good it gets at the moment. You know, you heard from Amjad earlier, this is like, you know, robots work like this. And there might be different robots coming out, but they all do the same. And, you know, it doesn't get any better anymore for us with that technology. And the future will change things again, because the future will not be that robot that you saw, or any of the other robots that Amjad showed you. And it's difficult to predict futures, and I'm certainly bad at predicting futures, but you can sometimes watch certain trajectories, like this spaceman that is just flying through space. I can predict where he's probably going to end up, just looking at the pathway he's taking. And when we look at surgery and how we do surgical procedures, these are the pathways that we are on at the moment, and I think that's where we're heading to. So we're going away from manual to more automated surgery, going from on-demand surgery to more integrated and augmented reality surgery. We're going from human, or away from human intelligence to artificial intelligence. And we are still on that path of going from invasive to minimally invasive surgery. So ultimately we will have this machine, maybe not in our time, but I'm pretty sure as long as surgery is needed, ultimately we will have that machine that is ultra intelligent and can do everything, and we are not really needed anymore. And I hope that we are not needed anymore at some point to do the handiwork. Maybe we will be needed to focus more on the patient's emotional sides than what we are doing now. And this is John Irving Good. He worked for the British Intelligence Service in the Second World War. He was instrumental in decoding the German Enigma machine. And what he said, he was a physicist, he said, the first ultra-intelligent machine is the last invention that we will do, because after that we don't need to invent anything anymore, because that machine will invent everything else. So this artificial intelligence is something that is already happening now. You know, the self-driving car is the typical example that people do. That's very simple. A car has to drive from A to B. That's a simple task, but that's just the very, very beginning. And it will touch surgery fairly soon, I think, but it will change surgery completely. The artificial intelligence revolution has started, and that's probably the next revolution after industrial and technological revolutions that we already went through. So with that, I leave you. Thank you very much.